Right, I'll make a start then. So for those of you that have not met me before, I'm Amna Khan Patel, the Clinical Fellow at NHS England and a pharmacist by background. It's great to see you all today. And for those of you that have joined us for the first time, just a bit of background around the ePrescribing Masterclass. These are a series of monthly webinars where NHS organisations can share learning and experiences on digital transformation to enable other trusts to fast follow in their footsteps. And the sessions are really designed to accelerate digital transformation, reduce unwarranted variation, and deliver quality improvements in patient safety, clinical outcomes, and service user experience. And the masterclasses are multi-professional, so we like to have presenters that are from the wider profession, including nurses, medics, as well as pharmacists, as part of presenting their work on digital transformation. Today, I'm really pleased that we have two different presentations. One is on the EPS implementation at Somerset, and the second presentation is the role of digital specialist nurses in improving patient safety. The masterclass will be recorded, and the recording will be uploaded onto the NHS Futures page. We are using Microsoft Teams as the platform, and after each presentation, I will invite any questions from you in the audience, and you can either come off mic and off camera to ask these directly to our speakers, or if you'd prefer to put them in the chat, then I can ask those on your behalf. And if any questions aren't answered during the session, we will make sure that they're answered after the session, and these again will be uploaded onto the NHS Futures page, as well as a copy of the presentation. So I will start by introducing our first speaker, Leo. Leo is the digital lead pharmacist at Somerset NHS Foundation Trust and has been working in this role for the past 7 years. During this time, he's led on the deployment of EPMA to the acute and community hospitals, including ED, and has been working alongside colleagues in the NHS and the NHS to deliver clinical improvements across Somerset through systems interoperability. And most recently, he has led the successful completion of the NHS England's assurance process for the utilisation of EPS in the trust. So I'll hand over now to Leo, who will do his presentation on EPS implementation at Somerset. Over to you, Leo.
Thanks, Amna. So just thought I would start this presentation with a bit of an overview of where we are in Somerset FT. So we've got 12 different hospital sites, including 2 acute sites and multiple community hospitals scattered throughout the whole of Somerset. And we cover all different care contexts with our ePrescribing system. So we provide community care, mental health care, and acute care. We've merged twice in the last 4 years. So we were a single organisation. We merged with our Somerset Partnership colleagues to take on the community and mental health aspects. And then we had a second merger across with our Yeovil Hospital just 2 years ago. So we're in a unique position where we have 3 different PAS systems for admitting, discharging, transferring patients. And we've got 2 different electronic documents management systems. So we've got plenty of scope for interoperability, and it's almost become a necessity working in our trust. We've got a single pharmacy team that covers the whole of the trust, and I lead on the digital medicines team, and we cover off all of the different medicines management elements in our digital clinical systems. And our goal is to have a single joined up medicines record across all sites, utilising interoperability, utilising the GP data that's available in Somerset. So just to sort of visualise that for you, we've got the CIDR record, which is our Somerset's integrated digital electronic records. This is where GP medicines consultation information all gets put into a central point. And we've got feeds from the county council for social services and things like that also go into here. We can then directly take that information or the medicines information into our EPMA system through a FHIR aggregator, which allows us to transpose the medicines on admission information directly into our system with very minimal need for transcription. We're then utilising that same e-prescribing system now for EPS to send prescriptions back out to community pharmacies. And we've got that same system integrated with our 2 discharge summary solutions. So we have eliminated the need for transcribing medicines on discharge as well, which helps with the discharge medicine service and will eventually help with getting that information directly back into the GP records. So we have that whole care continuity. Yeah, summarised here. So on to the main topic that you're wanting to hear about, which is EPS for secondary care. So this is an adaptation of the primary care system that's already been in place for a number of years and allows us to send FP10s electronically directly to a patient's nominated pharmacy via the NHS spine. Community pharmacies can then download that prescription and dispense it, or they can re-upload it to the spine, pass a token on to our patients, and they can take it to any other pharmacy that can try and dispense it for us. Because we utilise EPS within our own EPMA system, staff are already familiar with the concept of prescribing in that system. We've got a full history of the patient's medication, not just the FP10s that are written for EPS, but also any of their inpatient medications that are prescribed. And we've got full auditability of prescribing practice rather than having to wait for 3 to 6 months for EPACT data to then come back in to the trust then to analyse on FP10s. We had to go through the NHS's assurance process for the first of type. So this then allowed us to scale across our organisation afterwards. I can go into details around the first of type side of things, but I've not included it in this presentation because most people won't have to go through it. But we're focusing initially on our community services, mental health services and hospitals at home, areas that are currently having to send FP10s either directly to pharmacies or where our clinicians are having to transport prescriptions around the county using their cars after seeing patients in their homes. Basically focusing on areas where there isn't an outpatient pharmacy that's operated by the trust. So we're not looking at implementing it in our acute sites at the moment, except for areas that are having to post FP10s. We've got role-based access over this, so we basically control the tap on who can use the EPS functionality at the moment, which helps because there's an awful lot of technical setup in the background. And we've also got controls in place to sort of force formulary prescribing and to stop prescribers from prescribing anything that they want in EPS, because within our EPMA system, they do have access to the full drug dictionary by default. The service onboarding process is really quite arduous from a technical perspective because we're beholden on clinicians actually coming to us and providing us with the information that we need to set them up. So we can set up the elements around the cost centres because we've already got their FP10 information and the ODS codes that are linked to that. But we do take this opportunity as a way of rationalising the cost centres that already exist. Like I say, we've suffered from, I say suffered's a bad word, but we've had 2 mergers in the past 4 years. So we've got a lot of duplication of ODS codes from the 2 different acute sites. And our community mental health services were split into the 4 sort of corners of Somerset. So we use this as an opportunity to sort of rationalise all prescribing down into a single cost centre for each sort of clinical specialty. There is a requirement to set up a mesh mailbox, which essentially receives messages back from the NHS spine when prescriptions have been cancelled. Then that just notifies us of that prescription cancellation. As I was mentioning earlier, the user setup is the most painful element. Clinicians have to provide us with their smart card details. A number of clinicians, at least in our organisation, haven't had to use a smart card in years because they don't routinely use it. It's not a requirement of any of our PAS systems to log in via a smart card. So for some professionals, they are having to register for a smart card in the first instance, which can take some time. We also need to get their professional registration details, as that's a configurable element that has to be in the system and sent across to the NHS Spine. And from an NMC perspective, that information isn't readily available in the public domain. It's easy enough for GPs, pharmacists, and physios, etc. That's all on the respective governing body websites, but not for the NMC, unfortunately. So we are beholden on our clinical colleagues to actually provide the information that we need to set them up. I'll quickly whiz over the first of type assurance process, just for those that might have to go through it. You're basically put into a pilot where you're limited to 5 cost centres, and you have to show a prescribing and dispensing of 800 prescription items. You don't have to do it over 45 days. You can extend that out. 45 days is the minimum period that the NHSE assurance process requires you to be in first of type for, so it can cover off the BSA elements at the end of the month. And you have to show that your system has had no clinical incidents related to EPS, and you can't take a system update throughout the period of the first of type. But what it does do is it does provide assurance for that system to be utilised for EPS across any of the other trusts. So we use the Better Meds EPMA system. We've gone through first of type. That means that any other trust that uses Better Meds can now use it for EPS as well. As I said earlier, we've got a familiar prescribing system. So anyone that's used it in our inpatient setting has the same interface that they use for EPS. The only difference is that we mandate you have to prescribe at a VMP or a product or brand level, as that's required for the EPS prescription requirements. Unfortunately, we don't have structured dose syntax for EPS, which limits some of the interoperability that we can have within our own system. So it all has to be entered as a free text string for patient readability and to make it easier for the dispensing pharmacy to label up that instruction. But we do have additional wealth of data that isn't currently available in our prescribing system. So we've got available packaging built from the NHS BSA data. So when a prescriber is writing up a prescription for amoxicillin and they want to give a whole pack, they can see what the whole pack dispensing options are. There's also built-in logic that when they're prescribing controlled drugs, it will automatically fill in the CD legal requirements for quantity in words and figures and send that across too. And we've also got clinical decision supports. Again, that if we're prescribing for patients that are currently inpatients, that will trigger decision support against their inpatient chart as well as their EPS prescriptions as well. The system is configured to automatically endorse FP10 prescriptions based on the prescription type. So any borderline substances that need to have the ACBS endorsement will automatically be on there. But you also have the configurability to add additional endorsements that you would wish to add based on the products that you're prescribing. So just to give a picture of how EPS has changed our practice in Somerset, the information on the side shows the 3-month period on paper-based prescribing. You can see that we had 94 different cost centres, 97 nurses, but we only had 3 named doctors. Everybody else appears as hospital doctor because all of our FP10 information on paper anyway is costed against departments rather than individual prescribers. It makes it very difficult to discern who's doing what on paper. Over the last 3 months with EPS Live, we've got 5 services being utilised by 37 prescribers. We've done over 2,000 items. We've got full visibility of the prescriptions that our prescribers are writing in real time. And we've got full traceability of where prescriptions are in the supply process through the EPS tracker. We've built some dashboards to help monitor this, and it also means that our prescribers and our non-medical prescribers in particular that have requirements for annual audits on their prescribing can export their data and summarise it really easily. I just want to go through some of the use cases and why we chose to do EPS in the community environment in the first instance. On the slide is a single example of one of our hospital at home nurses going out and visiting a patient and writing a prescription for them, and then having to transport that to the patient's local pharmacy for dispensing and then ship it back to that patient. Not only is it a huge amount of time for our clinicians having to ferry prescriptions around, it's not good for the environment, and the trust has to pay out the fuel payment for that clinician to do that full journey. We also had reports from our services that we piloted with around lost prescriptions. Patients were reporting that the pharmacy never received the prescription that was sent in the post. And then contacting our prescribers, who then have to rewrite a prescription, write a new one, and hope that the other one doesn't miraculously turn up and the patient doesn't get a second prescription. We also had examples where prescriptions have been written, given to the patient has then tampered with that, and the pharmacy then have to contact our prescriber to confirm that's definitely what they wanted. Obviously, this isn't possible in a digital prescription. So we can see here with the patients that we were previously dropping off prescriptions to, 78% of prescriptions that we were writing in our hospital at home service were having to have a member of staff ferry that prescription to and from the patient's abode. After that, we still have 16% of prescriptions requiring staff to travel, but we believe that is primarily due to either patient preference to have a paper prescription that they physically know is what's going on and not trusting technology, and a combination of some difficulties around patient validation. So within EPS, you need to validate you're prescribing for the right patient based on a comparison between the data in our PAS system versus that's on the NHS spine. And where a GP record hasn't been updated recently, there can be misalignment between those two sources, and some of our prescribers are reluctant to prescribe where they can't truly validate that it is exactly the same patient that they're going to be sending a prescription for. But you see we've had a massive time saving for clinicians each month. We're saving money as well, and we're also making it better for the environment. For those that we posted prescriptions for, we've estimated that we're saving just under 10 hours each month in admin-related tasks, whether that be the signing out of CD prescriptions from controlled drug cabinets, the auditing of what's been written on that FP10 prescription. So our services traditionally would have written out an FP10 on paper, scanned it, and then uploaded it into our electronic patient records, and then sent that prescription via recorded delivery to the patient's pharmacy. That's all eliminated through the EPS tracker and the fact that we can just copy and paste the EPS tracking ID in the patient records, and clinicians can just access the full digital history of FP10s that have been written using EPS through our EPMA system. There's also a small time saving through clinicians having to support the safe destruction of prescriptions that were written in error as well. We'll see save postage costs and postage errors. It's difficult to give a true estimate on how much money we've saved through postage because nobody actually documents exactly how much postage they've spent sending prescriptions versus any other clinical documentation that's sent via the post. But we have had positive reports that there have been no reports of missing prescriptions since we started with EPS. Every piece of feedback we've had from our clinicians has been positive. There've been nothing negative has been said about the EPS functionality within our system, which is a true testament to the functionality that's being developed. As a number of us will know, people that go through digital change are often quite quick to complain and very slow to praise, but this has all been, like I say, entirely positive. There's not been a bad word said, to the extent that we have, for the first time ever, clinicians coming directly to me and my team asking when can we have EPS rather than when are we going to have EPS so we can stay doing what we know for as long as possible. So the next steps that we've got, we're looking to scale out across all of our community mental health services. We'll then be looking at the acute services that do remote prescribing as well. We see that's where the most benefit is going to be achieved. We've got to a point now, like I say, because we've got clinicians coming to us saying, when can our service go live with this, that we've set up basically a spreadsheet that clinicians have to complete to provide us with all the information that we require to set them up. And we can actually demand that they provide us with baseline benefits data so that we can actually monitor the improvements and share further learning around the benefits realization piece for EPS, which we know is in lots of digital change that often have been thought about last. And we're looking to do a full evaluation of our pilot sites and have the whole service across the county by the end of this year. Any questions? I've not looked at the chat. I have seen that some things have been put in the chat.
Hi, thank you, Leo. Does anybody first? I know there's questions that are already in the chat, but does anyone that's asked a question want to come off mic and ask Leo directly, or else I'll go through the questions that have already been asked. But if anyone does want to ask the question directly, happy for you to do that. If you just want to raise your hand or come off mic. Okay, there is some questions in the chat, Leo, and it's in the Q&A, and I don't know if you can see that, but I'll read it out.
Yeah.
So it's, with access now open to your clinicians, focus on replacing paper EpiPens, how are you preventing hospital outpatients prescriptions from being replaced by EpiPen to EPS, and are you concerned about a financial impact if outpatient prescribing moves towards community pharmacy prescribing? I guess due to less favourable drug type pricing and loss of preferential VAT arrangements.
So we've got configurability within the system to specify which prescriptions are not for EPS and which ones are for EPS. So any of the sort of high cost drugs that we'd look to dispense internally in our own outpatient pharmacy, we can basically configure those to be not for EPS, and they just won't appear in the drug dictionary for people wanting to prescribe it on FP10. The rules are really no different to what we previously had, where we had FP10s or internal hospital outpatient prescriptions. We still sort of where the hold on the prescriber choosing the right paper formats to prescribe on. We now just have a bit more control over which electronic format they use to prescribe by, let's say, configuring out all of those hospital only, or we have a traffic light system in Somerset, the black drugs in our traffic light system that are not for prescribing on FP10 at all. Okay. So yeah, that's how we plan to sort that out.
That's helpful. There was just another question around, has the implementation of the EPS solution had any effect on your EPMA functionality? For example, the way you prescribe discharge prescriptions?
No, they're two separate components. So we have a, let's say, completely integrated discharge functionality within Better Meds. So any prescriptions that are written on the inpatient drug chart can be directly pulled into a discharge prescription from the active drug charts, which is much quicker than copying and pasting or transcribing that into an FP10 on EPS. So because we're not using EPS in our inpatient settings at the moment, we don't have a huge amount of concern around any adjustments to discharge prescription or discharge prescribing. We do recognise, though, that if we were to move to allowing EPS in our acute sites, that one, it could help facilitate quicker discharges out of hours when pharmacy is not open, because they could just send that FP10 straight to a pharmacy for dispensing instead of waiting for ours to open. But we do also recognise that it then opens the tap a bit more, and anyone could start using it for any process. So it's something we'll just have to weigh up and agree as we move forwards.
Yes, no, I agree. Probably something you'll review internally in terms of processes of what you want to
Yeah.
do. And the question is around, is the EPS data being shared within the EPR for future review?
So it's not within our EPR. All of the medicines information that we have in our EPMA system is stored in our data warehouses, but because we've got 3 different PAS systems, it's very difficult to make it all available in every single PAS system. So what we do is have a central resource for the prescription information, and we can set up different dashboards and reporting options for staff that need to access that information. And I didn't have it in the slides, but all EPS prescribing is visible in a documents view within BetterMed. So any patient record you can load up and you can see every prescription that's been written in EPS, which also helps with some of the potential diversion situations that we've had. So one of the areas we'd like to look at with our Director of Pharmacy's permission is putting EPS into ED. We've had scenarios where drug-seeking patients have turned up on, say, a Wednesday, saying they're in pain and getting prescribed some codeine on an FP10 and sent away, and then come back in the next day, see a different clinician, get another handwritten prescription for codeine and get sent away. With EPS and having that full visibility of the prescription records, that wouldn't be a thing you'd see. Oh no, you had a FP10 for some codeine yesterday. What are you doing? Jog on. So yeah.
And just another, probably a few more questions, but a final one is there anything you'd wish you'd done differently based on the learning to date from the rollout? It's always that lessons learned.
So most of the lessons learned are actually through the first of type process. It wasn't the smoothest process, and we've actually fed a lot back to NHS England to try and make that smoother for other sites and other services, system vendors that are going through this assurance process. From an actual deployment process, the key lesson learned is not onboarding services until you've got all the information that you need. A lot of the management around creating accounts and making sure you've got the smart card information is really painful. Just waiting and waiting and waiting. We sort of had to just take a drip feed of that information when we went through the first of type assurance process, purely because we needed to get the ball rolling, and because we weren't informed of the full details of the first of type assurance in terms of you're limited to 5 cost centres and had to do 800 items. We went to relatively small areas that we thought would benefit most. I think if we'd had known in advance what the assurance criteria were, we would have gone to much higher volume prescribing groups rather than to our hospital at home service that was only at that stage quite a fledgling surface.
Great. Thank you, Leah. It was a really great presentation to see what you've been able to do at Somerset. There are a few more questions which we'll take offline just in the interest of time. But as you can see, you brought out a great discussion within the audience here. So thank you.
Brilliant. Thanks all.
Thanks, Leah. So we have our next speakers, Tomalea and Fru, who will be sharing their roles of digital specialist nurses in improving patient safety. Are you able to share the slides? Yeah. So I'd first like to welcome Tomalea, who will be sharing her presentation on the role of digital specialist nurses in improving patient safety. Tomalea is a registered nurse and an EPMA clinical nurse specialist who is committed to advancing healthcare through digital innovation. She bridges the gap between clinicians, nurses, and project teams, ensuring frontline insights shape digital transformation. With a rich clinical background spanning A&E, acute care, endoscopy, and specialist nursing, Tomalea brings both depth and versatility to her role. Her international experience and leadership skills enhance her ability to solve problems and deliver compassionate, patient-centered care while driving digital change. She holds a BSc in nursing and an MSc in Public Health and recently completed the Artificial Intelligence Programme at Syed Business School, University of Oxford, reflecting a strong interest in the intersection of AI and healthcare. Outside of work, she hosts Bites and Bedside, a monthly webinar spotlighting nurses who have transitioned into digital health and digital transformation roles. I'll hand over to you now, Tamalaya, for your presentation.
Hello, good afternoon, everyone. My name is Tomilayo Akeshiko. Thank you, Amna, for that introduction. So, if I have a penny every time someone have asked me, "What do you do in your role again?" I think I will have a jar full. So, in my presentation today, I'll be talking about my role as a digital specialist in the space of EPMA and what I've done around improving patient safety. So I'll be talking about what I've done in my role, what I'm hoping to do, and challenges I've faced in my role as an EPMA specialist. And then I think questions will come after my colleague's presentation. Right, so a bit of a background. So I at Berkshire Healthcare Foundation, we've had EPMA. So EPMA is provided by IMIS, which is now called Optune. So we've had it for about 8 years now in our mental health inpatient wards, and we've had it for 2 years in a community health inpatient ward. So our EPMA system integrates with our electronic health record. So that's provided by Real Access Group. And we use one system for our EPMA for pharmacy procurement, as well as our EPMA system. And also we have 1 out of 6 EPMA enabled depot outpatient clinic. And we don't have any other than that. And we also have our IMIS, which is also called Optune, linked to our pharmacy robots. Right, so when I think about my role, the picture come to my head is a bridge, and that's why I've put that in my slide there. So my role, I think it's primarily around bridging the gap. So it's bridging be a middle person between the very technical IT team and the clinicians, the pharmacy department, the training, and the IT department. So it's about bridging the communication gap between multiple professionals to enhance collaboration. And I do a lot of work around supporting education and training. I think there is a huge benefit around peer-to-peer support, especially in terms of when it comes to digital transformation, adapting and adopting change. And that's what I do in my role. I also see myself as a subject matter expert in terms of EPMA from the nurse's point of view. And I also hope I also help nurses to see themselves in that light, whether you're a research nurse, whether you're a stroke nurse. We tend to spend a lot of time with our patients. We are very much familiar with the workflows, the processes, and I think we are positioned perfectly to help and guide developing digital system that is frontline ready and frontline applicable. So, and also in my role, I help to I contribute to system design and implementation. So yeah, I just see myself as a middle person, basically making sure we're all singing from the same hymn sheets. And also, so in this slide, I was talking about what I do at the moment. So I started in this role about 2 years ago, and what I've done so far, I have developed an EPMA super user group, and in that group we have 1 staff nurse super user from each community ward and mental health ward. And I think the idea is to help nurses to support themselves and share best practice And also we had EPMA upgrade, a successful EPMA upgrade recently. So I supported in the floor walking and providing peer-to-peer assistance as well. So we also have a standard EPMA e-learning. And like I mentioned earlier on, I believe there's a strong value in face-to-face peer-to-peer support. And that's what I've done in my role as well. So I've created like a face-to-face e-learning, face-to-face learning. And this, what I've developed is it's based from feedback from EPMA related incidents. And as I'm sure we are all familiar that most of our SOPs are massive. They are in hundreds and thousands of pages. So what I've done also is to draft an easy to read point of care guide so that it'd be very easy for frontline staff to have something to make reference to easily in their work. I also I do a lot of feedback for practical changes to the MDT, to our EPMA MDT team. And I also do audits on our EPMA just to make sure we're complying to our SOPs. Right. In my next slide, so I'm going to be talking about what I'm doing now and what I hope to do in the future. So we're looking at putting patient photo on our EPMA system. So I'm working on drafting an SOP around that. I'm also I'll be doing a lot of work also around breaking down our EPMA SOP into small bites so that our staff, frontline staff, can have something to make reference to. And we also have, and I know this is not just peculiar to my trust, we have this issue around access to bank staff and agency staff. I think that's one universal issue. So I'm just looking at exploring solutions on how to do that. We also have a new business continuity for EPMA. So what I'm looking forward to do is to training more staff on how to use it so that every frontline staff know exactly what to do just in case EPMA is not available and all of that. So I'm working on that. And unfortunately, we still have issues around reverting back to papers and all of that. So I'm also looking at managing incidents around that as well. Right. So there, I think, and I might be biased because that's what I do every day. I think my job has got a huge benefit, but there are also challenges as well. And I think it's not just unique to an EPMA role. I think generally for duty nurse specialist role in some organization, it's relatively new. So there's a bit of challenge around job overlap, and that can create a bit of tension and confusion about responsibilities. And the next point is about staff instability. Again, this is not unique to my trust. We have high turnover in our clinical areas, and sometimes that can make it very difficult to make consistent engagement and training. And also we have issue around resistance to change. And I think resistance to change can be in two ways. We have the issue around people resistance to change because they feel that what you're suggesting might be more time consuming on top of what the hundreds and thousands of things that they have to do. And they might feel it might disrupt their workflows. But I think in that light, I think if frontline staff have peer-to-peer support, and if they're carried along from the beginning, for any digital innovation, I think there will be there will be good compliance. And there's also resistance in terms of some of our systems are not very quick to adopt, they're not quick to evolve quickly to align to the fast-paced, complex needs of frontline staff. So, and that lag can lead to a bit of inefficiencies, frustration, and even missed opportunities to enhance patient care through technology. I think, right, so that's the end of my presentation. I'm very keen on interacting and connecting with G2 nurse specialists around. So please, if you've got any question, please be in touch. And I'm also on LinkedIn. Thank you very much. That's all for me for now.
Thank you, Tomaleo. And I'm now going to introduce Fru. Fru is a digital medicine clinical nurse specialist at the Royal Cornwall Hospital's NHS Trust. And she's a dedicated registered nurse with over 5 years of clinical experience, currently serves as the clinical nurse specialist in digital medicine. And over the past year, she's been combining her frontline nursing expertise with digital innovation to support safer, more efficient care. And her work focuses on integrating technology into clinical practice to improve patient outcomes and streamline healthcare delivery. I'll hand over to you now, Fru.
Hello, everyone. Thank you for the introduction. Can you all see my slide?
Yes, I can see the slide.
Okay, so my name is Fru Asoba, and I'll be giving a presentation on the role of digital specialist nurse in improving patient safety. So a bit about Royal Cornwall Hospital Trust. It's made up of 3 hospitals. The main site being a Royal Cornwall Hospital with 760 beds, St. Michael Hospital, West Cornwall Hospital. We have about 480,000 residents across Cornwall and Isles of Scilly. We are still using the EPMA, and it has been live since 2012. We have different digital systems, but we are looking forward to getting our new EPR, hopefully by 2026. So digital nursing has been existing in Royal Cornwall Hospital for quite a while. We have nurses working in the e-health team since 2016, and they are in charge of our legacy digital system. We also have a digital medicine team, which is my team, and they're in charge of anything medication and technology. We also have an EPR team, which was formed for the purpose of implementation of our new EPR. So what is interesting is all of this team have an individual contribution to the implementation of our new EPR, as well as do their normal business as usual. So the timeline of nurses in digital medicine team, we've had 2 temporary nurses using during EPMA rollout in 2012. And then we proceeded to getting 1 specialist nurse in 2016, who was involved with designing ward workflow around medication and how it integrated with the medication round and digital system. He was also involved with rollout of our pharmacy ordering portal in designing and communicating with the wider nursing team. Hence why his job title is the clinical nurse specialist for digital medicine and medication optimization. Then in 2024, we had 2 nurses, the lead nurse and the junior specialist nurse, which is me. Okay, so these are the systems our nurses are using with EPR and barcode, which will be available by next year, 2026. So let me emphasize a few key points here. We have about 500,000 administered medication in 1 month, and we have 5,053 active EPMA registered nurses and midwife users. Why am I sharing these figures? This is to highlight to you that we have more nurses involved with medication compared to any other groups. So it just makes sense to have a digital nurse in the pharmacy to better advocate for them, thereby improving patient safety. And that is where I come in. So if I were to summarize my role, I would say I am in the middle of technology, clinical team, and pharmacy. What makes my role in pharmacy department paramount is I'm the first point of contact for nurses. They are more likely to complain to me or give me an honest feedback. I'm a link between them and technology and between them and the pharmacy. Because I have clinical experience as a nurse, I'm the best person to advocate for them and patients. I'm able to observe their needs and challenges and action it or channel it to the right people. So I'm going to dive more into how my role improves patient safety. As an educator and an enabler, I'll say because I am a nurse and I have interacted with many nurses. A good number of us nurses are not quite techie, and this is because we don't have formal training on it. And so because of that knowledge, I know how to train and support staff, empowering them to use digital system confidently and safely. They'll be easily open to me as I understand them better than the rest of the team. I also go about answering general queries regarding digital medicine team. A good example, which is one of my favorite, is being able to answer a clinician or a nurse call swiftly, as I've been in a situation where technology is failing. I've got outstanding medication. I have a patient that needs patient care. And the last thing I want to be doing is dealing with technical issues. So as a safety and quality champion, I carry out regular checks and I take actions. As a nurse, I can better predict a scenario just by looking at the report. Just because I've worked in the pharmacy and my nursing experience, I realized that pharmacists communicate with the nursing staff by writing on patient's note. That is something that most newly qualified staff or junior staff probably don't know. A good example will be a medication was ordered, but it wasn't delivered by the pharmacist. Pharmacy writes the note, nurse doesn't see it, and medication is left outstanding, and no appropriate action is taken. And so that is where I come to support the nurse. I also support in maintaining our continuity plan. I also go about ensuring right people have access to the system, which will make nurses feel safe practicing and patients feeling safe. My role as a collaborator and communicator, I work with a multidisciplinary team, suppliers, and patients to ensure digital solutions are clinically relevant, working, user-friendly, and continuously improving. I go about my ward walks asking ward manager the challenges they are facing and building network and making myself approachable. My role as an innovator and implementer, a good number of us nurses will love technology that help us get time to be able to take care of patients. So implementing and encouraging self-administration for wards that can is one of the innovations I do. Example, we have a ward that has a digital log but not fully using it, and this is because the ward manager was changed and staff move around. So the present staff are not quite good with using the logs. So I plan on carrying out a before and after of digital logs to show the ward manager the benefit. I also go about using my nursing experience to promote clinical safety of our new EPR through workflow analysis. I'm able to see issues with workflow that pharmacists probably will not pick up, or ask questions that pharmacists will probably not think of. So talking a bit about my challenge, I could just identify, as of now, I could just identify one challenge, which is imposter syndrome. Initially, it was challenging moving from the ward environment into a digital team with less patient contact. Some aspects of digital medicine were new to me when I started the post, so this role has been a great learning experience. However, I'm enjoying advocating for nurses and patients in the pharmacy world and I've made valuable contribution to the digital medicine team. To conclude, given that nurses represent the largest segment of the healthcare workflow, it is essential to understand their perspective and needs. Utilizing nurses in our digital team can leverage their experience to better advocate for this group and help promote patient safety and quality improvement. Thank you.
Thank you, Fru, for that great presentation and insights into your role. So I'll first open it up to the audience. If anyone wants to come off mic to ask any questions for Tomalea and Fru, please do come forward. There has been a question around, I guess, maybe it's a practical question around, how does a nurse transition from the actual bedside into a digital role? And around, I guess, from my understanding, is like, what experiences would you need to be able to actually, be qualified for those roles? Because like you said, it could seem quite a jump from going from the bedside to digital. And I guess for both of you, any insights or any things that you did to prepare yourselves for those roles would be helpful.
Do you want me to go first, Fru? Yeah, right. So I think I get that question a lot from people. When, yeah, especially I get a lot of question around, oh, how did you get this job on LinkedIn? And what I try to tell my colleagues, nurses, is that your clinical experience, I think, is a superpower, if I can use that word. I think it's very natural for us to think, oh, I need to do that extra. Do I need to do an extra course, or do I have to do that training? And I think if you have opportunities to do that, please, by all means, do those trainings. But I think what is important is your lived experience as a nurse, working in an acute ward, working in a mental health ward, as a research nurse. I think in whatever capacity, I think that is a strong point, and that is what is missing when it comes to, in some spaces, especially people who are very technical on IT, very technical. They don't have that lived experience, and they are in the position sometimes to develop software or app or to be used in the front line. So we are in that best place to say, I've got the experience. Let me just share. Let me guide you on how to do this. Oh, I don't think that will work practically. That looks brilliant and shiny, but probably that will not work practically in the front end. So I would say our clinical experience, I think it's a strong point, and I think it's what we need to sell more than any other training. Yeah, I hope that helps.
Yeah, that's great. Fru, do you want to add anything to that in terms of your own experiences and journey?
Yeah, I would say the experience, like she said, and and also having a mentor. Tomilayo was my mentor, and so she was of great help when I had this interview. When I had my role, she was of great help getting, helping me on how to answer the question. So getting a mentor is what I would say.
Yeah, that's great. And Tomalea, you mentioned around that you want to have this network for digital nurses. Did you want to expand? Do you want people to reach out to you directly in terms of, creating this sort of network for you all to collaborate and exchange ideas, etc.?
Yeah, absolutely. Thank you for reminding me. Yes. So I know we have nurse informatics in different trusts, and we also have digital medicine specialist nurses in different trusts. So I'm hoping that we can all come together, network together, and share best practices. So if you're number one thinking about if creating this role, if it would have a bit of benefit for your trust, I would say please go for it. Set up that role in your trust if you don't have one. And if you have an EPM specialist in your trust, please feel free to share my work email address so that we can form a good network. I've got Fru now, so we can build that team together. Thank you.
Yeah, I'll just leave my email on the chat box too.
That's great. Does anyone have any other questions? Yeah. Oh, there's been a comment in the chat which I'll let you see. So
Fantastic.
I'd like to thank both of our presenters today and for sharing their work. So there was a great conversation around EPS and what that's meant for Somerset in terms of, you know, the benefits that they've seen since adopting that. And then our second presentation around, you know, the role of digital specialist nurses, which we hope will be a growing field, and there'll be a network hopefully that you'll be able to create some momentum to really support that development of those roles, and how they actually do make benefits to organisations in terms of the patient safety aspect and the clinical insights that you will bring. In terms of our next ePrescribing Masterclass, it is on Wednesday, the 18th of June. Please do scan the QR code and register for that event. And if you do have any ideas for future topics, or you'd like to feedback or volunteer to present at a future masterclass, please do email Rosina, and she'll be able to share the information of the process for presenting. And also, if you do have any ideas, we'll be able to look at planning those into the future topics for the webinars. And the webinar is recorded, and that'll be uploaded onto the future site, and the slide deck will be also available on the website. So you'll have access to that in terms of the resource after the event. And if there were any outstanding questions, but I do think they've all been answered now in the chat, they'll be added onto the futures page. Thank you again to our speakers today. It was great to hear from you, and thank you as an audience for your time. And I look forward to seeing you in June on the next ePrescribing Masterclass. And I hope you have a great rest of the afternoon. Thank you all.
Thank you.